Hi, everyone. Welcome. I'm Julie Clower, a patient, stage 4 patient, as well as a Colon Town cabinet member, and also admin of various and assorted Colon Town groups. And it's wonderful to have you all here today. And I'm very excited to introduce our doc talk today. Because for a couple reasons. One is the liver folks seem to be getting a lot of information from the doc talks, and we don't want lungs to be left out. So very happy to learn more about what's happening with lungs for colorectal patients. And then also because our guest is my surgeon. So let me tell you a little bit about him. He specializes in thoracic surgery at USC, the Keck Medicine of USC. He focuses on malignant diseases of the chest. And he completed his training at Beth Israel Deaconess Medical Center, Harvard Medical School, and did fellowships at MD Anderson Cancer Center, as well as further training at the National Institutes of Health, and doing a clinical research fellowship in surgical oncology. So he has a lot of amazing experience. And I would tell you that my last conversation with Dr. Atay after my surgery was something like this: "You're amazing. Thank you for the exceptional care, for saving my life. And I hope I never have to see you again. So goodbye forever, I hope." But I'm so excited because it's not goodbye forever, because this is a very exciting reason to get to see him. And it's not because my disease has created issues. So good to see you again, Dr. Atay, under these much better circumstances. So now I'll turn it over to you.
Well, thank you very much for all of those kind words. I appreciate that. And thanks for having me to kind of give this talk here and try and avoid, like I said, we don't want to ignore the lungs. So I will go through kind of a little bit about surgery for metastatic colorectal cancer, lung surgery, that is. And then I think we had some questions that I'll run through some of those already with some answers, then, obviously go over any additional questions that people have. So hopefully this will be relatively informative. I've tried not to make it too technically dense, so it should be, it shouldn't be an hour of falling asleep, I hope. So I will share my screen here and make sure that this is, I think we should be working. We all set, Julie, that comes up. Okay.
Yep, it's good.
All right. Well, great. Okay. So as stated, so I'm one of the surgeons here at USC, and we're fortunate because we have a great team, which is a big part of this. And we'll talk about that a little bit more too. But we work very closely with our oncologists, our radiation oncologists, everybody here. And I function as one arm of a pretty big team here. So the first thing that often I get asked is, am I in the wrong room? So what does a chest operation have to do with colorectal cancer? And as a lot of the liver is typically the most common distant metastatic site for colorectal malignancies. The lung follows thereafter pretty quickly. And so in a large percentage of patients who will be presenting with either liver and lung or lung-only metastases, we'll see them in consultation to discuss if there's therapeutic options that exist. And so I guess just to run through kind of what I want to touch base about today, we'll talk a little bit about sort of the incidence and presentation of lung metastases. And then when we do surgery or the indications for it, we'll talk a little bit about the types of surgery or the techniques that are out there that you might expect to hear about, and then the outcomes and the expectations for longer term. And then obviously to answer any questions that anybody might have to try and kind of get you more informed and moving forward. So what's the incidence of metastases? Well, we know, again, liver is the most common. Lungs comes next. It's hard to know the exact incidence of lung metastases, but somewhere for those who do develop metastases, between 10 and 40% are going to end up with disease in the lung. And the reason I say it's hard to know is often patients at end stage will have diffuse metastases. And so we don't always want to account for that when we're thinking about the disease that's intervenable. So again, somewhere in this 10 to 40 range is what you'll kind of see quoted. Any of those numbers is probably more or less correct. Rectal cancer, as the rectal part of colorectal, it's even a higher incidence of lung metastases, often isolated, and that's because of a little bit of difference in the physiology of that location anatomically. And I'll show some pictures about why that's the case and why that represents an even higher percentage of patients frequently that I will see for surgical evaluations because of the unique behavior of rectal tumors. So colon cancer is unique, and this paper that came out a few years ago is a great one because it really helped validate a lot of what we think. You'll hear about a couple different ways that tumors spread from point A to point B. In lymph nodes, so draining lymph nodes in the region of the tumor, which your colon surgeon, your general surgeon, your colorectal surgeon is going to try and get a bunch of lymph nodes out, and they'll talk to you about those after your surgery. And then what we call hematogenous or bloodborne. And these are via draining veins, we think, back to the liver, which is the drainage pattern of the colon, or directly back to the lungs, which is specific to the rectum. And there's a big study by people markedly smarter than myself who looked at the origins of these, and they noted that actually about 65% of the distant metastases had a totally different genetic makeup than those that were in the lymph nodes. So there's something different about the disease when it spreads to liver, lung, or distant than when it spreads to lymph nodes. And so maybe when we look at these diseases, when we look at colorectal cancer that goes to lymph nodes and colorectal cancer that goes to liver, that they're not exactly the same disease. And we bundle it all into one big picture of cancer, but really there may be something separating them genetically, and that can help us understand who and how to intervene more effectively. This is a little schematic about rectal cancer, why it's even more interesting as a surgeon, why I think it's interesting. Here's a little schematic of the rectum. Probably weren't planning to look at this today, I'm sure. But when we have colon malignancies, the majority of patients that would drain into what's called the portal system. And that system of drainage, the portal vein and the mesenteric vein, that drains back to your liver. And so if you have tumors and they are hematogenous and they're spread, then they're going to end up first filter is your liver. Your liver is a big giant filter, and it's going to get trapped there, and you're going to get metastases that grow. And then anything that gets past filter number one, then it's going to make it to the next filter, and that next filter is going to be your lungs. And so that's why we frequently see liver and lung. But for tumors that are down lower in the rectum, they don't drain to the liver first. They actually drain right back into the vessels that drain your legs, what are called the iliac vasculature. And those drain and go right past the liver. They skip it entirely, right to your heart and then to your lungs. And so for patients with rectal cancer, again, it may be a totally different disease biology, or it behaves differently. And these are individuals who we see with isolated lung metastases. And maybe another reason why they have even more opportunity for intervention from a surgeon such as myself. So what does it all mean when we think about this? Well, in my mind, it means that metastatic colorectal cancer can be treated with local therapy in the appropriately selected patients. And when I say local therapy, and I'll probably use that term a lot today, I'm talking about either surgery, talking about radiation, talking about ablation, even things like isolated lung perfusion, really things that are local, meaning they're just addressing disease in one specific location, as opposed to systemic, which is what we think of when we talk about chemotherapy or immunotherapy or anything where really the distribution of that treatment is to anywhere in your body where blood or fluid goes. And so even though colon cancer somehow is getting into the bloodstream or into the lymphatics, we're finding ways to locally treat it. And so that's what I take away from this, again, and what makes colon cancer unique and interesting as a clinician. So that's why you're here. That's why you're in this room, is because there are options for you with people like me. So understanding cancer. So how do we understand cancer? I don't understand cancer. And that's another big thing that everybody, I think, should know is that if anybody, your oncologist, your surgeon, your radiation oncologist tells you they understand how cancer behaves, they're lying or they're a genius. And it's probably, maybe it's somewhere in between, but we don't totally get it. And so everyone's case is very unique. And that's why what I'll talk about today is what I'd call surrogate markers for disease behavior, which is we're trying to understand how you and your specific case is going to behave. And we're going to use some sort of blunt instruments to help predict that. And so we don't know exactly what it is. And again, that little schematic and study I showed about the different gene profiles, that was a really nice study, like I said, by some very smart people to understand it. But we still don't know exactly why that 65% is the way it is. We know it exists. We just don't know why. So we're closer, but we're not there. And so so there was a really smart surgical oncologist named Blake Cady, and this is a quote that anyone who does a lot of cancer surgery has heard a lot of times, but it's very valuable here, is biology is king and patient selection is queen. Technical maneuvers are the prince and princesses who try and fail to usurp the throne. And what that means is the biology of the disease, that's what's going to drive the outcome. And then selecting the right patient for treatment, that's what's going to help. Technical maneuvers, that's surgery, that's radiation, that's ablation. Those are things we're going to try all these different ways, and we're going to fail unless we understand the biology. And so that's where, again, we work together to try and get the best possible maneuvers that are going to match that biology. And so cancer is a systemic disease. We're treating it locally. For some reason, that works. Again, we don't understand that, but it's the way it is. So what more can we do? So we found this tumor. It's in your lung. What do you do now? Well, the first thing is always talk to your oncologist. Systemic therapy is usually the first line. And so when I see patients with metastatic cancer, if they've never received systemic therapy, a lot of the times I'm going to tell them, even if this is a resectable tumor, if I say I can take this out, it's not a big deal, still getting systemic therapy first is often the right choice, because we want to make sure that disease is controlled. So you may hear that. But as soon as you get a tumor in your lung, talk to your oncologist and ask. If you have lung metastases, see a surgeon. Someone who's typically thoughtful and your oncologist thinks highly of, I'm sure, we'll have that conversation with you about when the right indication is. Because deciding whether to get a lung operation is always multidisciplinary. It's not just the surgeon it shouldn't just be the surgeon make the decision. It should be the surgeon and the oncologist and the radiation oncologist and everyone together putting a comprehensive plan together. And what is that comprehensive plan? That's what we'll talk about. How do we select? And this is always the biggest question is, how do we know who is right for removal of lung metastases? So this may be the more interesting part of it. These are the criteria I, as a surgeon, use. And these are, I think, the criteria that really the majority of people will use. Is one, you need to control the primary tumor. This can be with surgery. This can be with definitive chemoradiation. But the bottom line is the primary tumor, that colon or that rectal tumor, has to be managed. And if you can't manage that, then there's no point in taking out the metastases typically, because you're going to just get more, because these metastases all come from that primary. So if we've met criteria 1, then we look at 2. Ability to control all sites of disease. If it's liver and lung, that's okay. You just need another surgeon. You need a good hepatobiliary surgeon. So the point is, you got to have a plan for everything. You can't just kind of wing it and say, we'll do 1, we'll do 2, we'll see what happens. You want to have a comprehensive plan. Again, whether that's all surgery or surgery and radiation or whatever it is, all sites of disease need to be controlled. 3, and this is the hardest one to predict, and this is why we fail, is control of systemic disease. So what I, as a surgeon, want to see or not see really is, I don't want to see new tumor each time you get a scan, because then it means systemically we're not controlled. Because if you get I can go take out all the lesions on one side of your lung, and then by the time we get to the next one, your lung's filled up again with tumor. So we need to control it systemically, and this is often the hardest thing to do, or to know if we've done. But progression, as it's defined, or what you might see when you read a CAT scan report when you're looking at them, they might say progression of lesions. Progression of a lesion that's there, that doesn't bother me. or shouldn't bother most surgeons, which is if it was there a year ago and it's just getting bigger, that doesn't imply systemic disease is not controlled. That just means the local disease isn't controlled. And that's what we do best, is local control. So progression of known lesions is not a problem. New development of lesions, that's where we slow down and start thinking twice about doing surgery. So those are the general criteria. So say you've made this decision, we think you're a good candidate. Well, local consolidation comes into a lot of different forms. It can be surgery, but got to resect everything. It can be radiation. That can be SBRT or IMRT or SABRE or any number of acronyms that honestly I couldn't even tell you what half of them mean, but something with radiation or ablation, microwave, cryo, RFA, they're all very good. And the best choice of treatment is patient and lesion dependent. So the best cancer therapy is not always the best specific treatment for the patient, meaning we might say you need an operation to take this out, or I could offer you an operation to take it out, and that's the best therapy for the cancer. But if it leaves you debilitated, it's not the best choice for local control. So this is where we balance the risk and the benefit of these operations. So now we're thinking about, we've decided we're going to do surgery. So we said that's the way to go. How do we make decisions about how to approach it? Well, one, can we address all the lesions, as mentioned before? Number of lesions, that is prognostic, but it's not a hard stop, okay? Isolated lesions are best. So if you have one, that's the best case scenario. Well, 0 is the best, but 1 is good. After 1, anything less than 4 is probably falls into what I call the good prognostic group. Greater than 4, we know that the tail of that sort of survival curve peels off, but it's still acceptable if you have the right patient. Meaning if they meet everything else, which is primary control, systemic control, ability to tolerate it, all sites of disease, then it doesn't matter the number. You just have to be able to meet the criteria and get it done. So there's no hard stop. You just have to address all of them. The lungs don't regenerate the way the liver does. So the liver hypertrophies and you can get function back. You can take out 2/3 of the liver, I think is what they say, and you can get most of that function back. The lungs don't really regenerate the same way, but the lungs do hyperinflate. They're balloons, and so the balloons will get bigger and fill up your chest, but you don't get the same recovery of function. And so we really work hard to preserve volume when we're doing these operations. And in some cases, we decide it's too much volume, but we still want to address all the lesions, and that's when we do a hybrid approach. Surgery for some, radiation for others, and we try and get everything treated that way. So that's the decision making when we're approaching it. So what is it now? What is the operation going to look like? Well, you're going to hear terms like VATS or robotic or thoracotomy or sternotomy. VATS and robotic typically imply a minimally invasive approach. So that's using a camera, some small instruments, or a robot. Thoracotomy, that's going to be a rib spreading type of operation. Usually an incision along your side under your shoulder blade. And sternotomy is going through the middle, so a sternal split. They all have a role, and depending on the location, the type, and the comfort of your surgeon, you might see any of these being done, okay? You'll see incisions that look kind of like this. So this is a thoracotomy incision along someone's side. This here is from a robotic operation, so a couple of these things here. This is from a VATS operation. You know, you add up the length of the incisions, they're all probably about the same. The scar is going to be the same. So the morbidity of these operations is not the size of the incision. The morbidity is what's going to happen on the inside, which is how much of your lung we're going to take out. So we want to minimize the morbidity, but we also want to do a good operation. And so you may get offered a variety of techniques, and it's really the one that's going to get you to that outcome is what's going to be best. So I have and before I play it, I do have a little video to show some surgery. So if anybody is a little squeamish around blood or doesn't want to watch it, you can look away here for a few seconds. But this is just to kind of see what one of these operations, a minimally invasive one, might kind of look like. Okay. So this is how it looks when we're doing this. Is a left lower lobe lesion that's being done with a robot. And so these arms here are being controlled by a surgeon at a console sitting in the side of the room. These are some arteries that are being dissected that are going to the part of the lung that needs to be removed. That big thing coming in, that's a stapler that staples and seals. And you can see that's the arteries that are getting cut right here. In a minute, we'll see they'll cut the bronchus. That's this right here, the windpipe that goes to it, and that frees up that entire piece of the lung. So this is what a minimally invasive surgery looks like on the inside. So again, it might be a small incision on the outside. It's still something on the inside. But the robotic approaches, minimally invasive, are very good. It gives us a lot of flexibility, and I think the outcomes are great with it. So when we talk about these different types of resections, what are the extent of the lung resection? Well, you'll hear terms like wedge, segment, lobe, pneumonectomy. This is how much lung's coming out. And so a wedge is just that. It's like a little piece of pie. You kind of just grab a little bit of the lung and sort of chip a bit off. That's the preferred technique for metastatic tumors, the wedge resection. And the reason for that is it preserves the most amount of lung and ideally gets you the same outcome. Segment, that's the lungs divided into lobes, and the lobes are divided into segments. It's just how the blood supply and the windpipe goes to it. That's a bigger piece of lung, but it's still, I'd say, we call it sublobar, or less than a lobe, meaning if we have a lesion that's a little deeper in the lung, we might consider doing a segment, and that's a way to try and preserve, again, more of the lung. A lobectomy is removal of an entire anatomic lobe of the lung. You have 3 on your right, you have 2 on your left. And that's probably reserved for tumors that are very central or close to some vasculature or some windpipes where you just can't get to them any other way. And that's a substantial component of the lung. It's not totally inconsequential, but it's a pretty well tolerated operation typically. The lobes on average are about somewhere between 30 and 50% per lung. So the left side, it's basically 50-50, the upper and the lower. And on the right side, it's about 30 on the upper and then 50 and 20 in the middle and the lower. But if you take out, a half of your left lung, you're still only losing about 20% of your total lung function. So it's a tolerable thing for the majority of patients. Pneumonectomy, that's a whole lung. It's reserved for really specific and extreme cases. It's pretty uncommon to do that for metastatic cancer, although it is done if someone has a very difficult to treat lesion otherwise and has isolated disease and can tolerate it. It is an operation that is done, and we will do it if necessary. So what should we expect? Well, it is surgery, and recovery is dependent on the type of the operation, the amount of lung that's removed, and someone's functional status beforehand. We do always check your lung function for people who've been through it. You do these breathing tests. They're not the most fun things to do, but you check your breathing beforehand to make sure you're not debilitated afterwards. And debilitated is a relative term. That means you may notice that you had surgery, meaning you might get a little winded, you might be a little more fatigued, but we try and get you to a point where you're still going to have a quality of life that's valuable to you. Okay. The operations can be 45 minutes to 5 or 6 hours. It depends on how many lesions we got to take out. Hospital stay 1 to 7 days. Most people, it's like 2 to 4 is about average. Will it hurt? It will. Will it be manageable? It will. Can you breathe afterwards? Absolutely. You can breathe, you can walk, you can run, you can kayak, you can dance. If somebody who does a lot of yoga, they're a yoga instructor, you can do any of those things once you recover. And that takes time. It's not the next day, but 6 weeks, most people are doing their normal activities of daily living. It can be 3 to 6 months before the lung function fully recovers, or you're kind of past some of the more sort of annoying side complications that come with it. But it is a manageable thing. So this, there were a lot of great questions that had sort of come up that I've been forwarded, and so I wanted to run through those because I think it captures a good component of what we talked about and what people really want to know. And so one of them was surgery or observation. So if you've got a small nodule and it's isolated, should we watch it? Should we take it out? If it's isolated and can be resected with low risk, I think taking it out is a good decision. If it requires an extensive resection, then observing it for stability is a good call too. And the reason for that is you rarely will lose the ability to resect small peripheral lesions when you observe them. It's unlikely with close follow-up that they will go from 0 to 60 so fast that you'll lose that intervention. So I think small nodules, it's okay to observe. How long should you monitor it for? There's no real great hard number, but if you have a nodule that hasn't changed in a couple years, usually let's say 2, and it's low risk, meaning you don't have other sites of disease that are active, then at that point we usually extend surveillance where we'd be looking at a lesion every year as opposed to every 3 months or closer. But that's how long I usually watch it. Pretending we took away the known history of a lung cancer or of a metastatic cancer, a 5 millimeter nodule at 2 years, we don't worry about it anymore. Surgery or ablation for the lung. So SBRT, cryo, RFA. Well, when you're a hammer, everything's a nail. So I'm a surgeon, so my nail is to do operations. So it's easy to say surgery is the best. It's probably better, but it's better for certain things. So when we look at resections, surgery has a lower risk of local recurrence. That means recurrence in field or at the site of the operation. And there's a big series of this that was done at MD Anderson that demonstrated that differential outcome. But there's a higher risk of treatment-related morbidity, higher risk of perioperative morbidity. Ablation, on the other hand, has a higher local recurrence rate or in-field recurrence rate, but the treatment toxicity is much less. And so which one do you do? It's a decision that you make. It's a decision you make with your surgeon, with your oncologist. What's the best treatment for you? And that's where understanding the disease behavior, that biology, is really important to know what's going to be the best. Do we take a lot of risk, or do we have a concern that there's going to be more disease later and we should do something less invasive? One does not preclude the other. You can resect now, you can ablate later. You can ablate now, you can resect later. So you don't have to worry typically about that. As a surgeon, we used to try and avoid operating after SBRT, but it's become so ubiquitous that now we've gotten pretty used to it, and we do it frequently. So it does not preclude it. So here's a little case of this. This is a real case of a patient who had 4 lesions. They had surgery on all 4, and then they had a local recurrence. And so I'll show you on the scan. So this little dot right here, this is a tumor, very small, on the right upper lobe. They underwent surgery. You can sort of see some scar over here on the left where they had done it. And this little dot here starts to come back. This is about 2 years later. So they got SBRT. And then another 2 years later, it looked like this because the SBRT failed. They had an infield recurrence there. And so they got surgery after this, and we removed the entire lobe. This was a wedge resection here. So you can get surgery more than once, as you saw here. You can get surgery, and then you can get radiation, and then you can get surgery again. So you can get multiple operations, and you can have multiple modalities, and that's a very acceptable practice if need be. So this is a good example. A very small lesion, again, in and of itself would not be problematic, okay to observe, progressed very slowly over the span of a few years. A lot of this is radiation-related changes. The tumor's not actually this big, although it looks a little bit ugly, but that's mostly from radiation. So like we talked about recurrence rates, what are the recurrence rates after surgery? Local recurrence rate, I quote patients somewhere around 10%, maybe 15%. And that means that either the margin is too close and they will recur at the margin, or there is missed disease that we just didn't see. But around 10%, that's supported by most studies. But recurrence rate distant is a different number. And that's the one, again, that's hard to predict. So recurrence in the lung, again, somewhere brand new, that really depends on the individual that you started with. So did they have 1 lesion to start and they were 5 years out from their primary, or did they have 8 lesions to start and they were 6 months out from their primary? Those are different patients. And even though the local recurrence rates are the same, the distant recurrence rates are going to be different. And so that really depends on other factors on top of it. But for local recurrence rates, I say around 10%, and that's reasonably well supported. What about size? Size of the lesions. How big can they be? It doesn't matter. Size doesn't matter. The biggest consideration, again, is location. And the ability to identify them all and resect them while preserving enough lung for you to function. That's what's most important. So if it's a really, really big lesion, we can take it out. If it's a really, really small lesion, we can take it out. But you might have a really small lesion in a really bad location, and that becomes a more difficult thing to address. And I think I have an example of that here too. So yeah, here's a good example. This goes back to the waiting question too. There's another patient. The lesion is this little dot where my cursor is right here. This is in the right upper lobe. Here's another scan. This is a little more than a year later. So they've progressed a very small amount, like 1 millimeter over a year. Is this a good candidate for surgery? It's not really. They're not great. And the reason for, they have a couple other lesions, but the reason for that is this is very deep in the lung. So doing a wedge resection would require me to cut all the way into this lung and around it, and you'd lose a big chunk. And you say, well, is that amount of lung loss worth it for this patient? And this patient had a lot of other lesions and would have lost a lot of lung, too much lung, in fact. And so this was a lesion we opted as a group to do radiation with instead. We said it's too much lung, and we're worried the recurrence is going to be too high, or meaning we're worried they're going to recur. It may not be worth the risk of the operation. So this patient underwent radiation instead. Okay. So size isn't as big an issue as location frequently. What about combining resections? So liver and lung. Absolutely. You can do that. And it's really dependent on the extent of the disease that's necessary. So if you have a big liver tumor and a small one in the lung, sure, do them both. If you have a big lung tumor but a small one in the liver, do them both. If you have a big lung and a big liver tumor, maybe do those separately. So it's really, can you do it safely? We don't want someone to have a bad outcome because we tried to do too much at once. But if you have tumors that are progressing quickly, where you say, I don't think that it's a good idea to do a liver operation, recover for 3 months, and then do a lung operation, then we wouldn't. We would try and do them together. But it's mostly related to how complex the operation would be. So we do that here. If we have isolated liver, small lung, we'll frequently do those as a simultaneous operation. Sometimes we can even do them through the diaphragm, which saves the patient's incisions on their chest. The liver surgeons do their work, and we just cut a hole in the diaphragm from below, and we do it that way. And then no incisions on the chest. So there are ways to do it. What about some other experimental options, or sort of less common ones that maybe people hear about? So one of them is isolated lung perfusion, or what's called lung suffusion. So this is a technique that's been around for probably, 30 years or more. It was trialed for a variety of different things. Initially, it was actually for metastatic sarcoma. And the thought process behind it was just giving enormously high doses of chemo that would otherwise not be well tolerated systemically to just the lungs, where maybe the burden of the disease for these patients are. Sarcoma was unique, similar to colon, in that it often goes only to the lungs. So it does work, in the sense that if you get an isolated lung perfusion and they're able to technically accomplish it, it will work, but it doesn't always lead to durable regression. So meaning the metastases will get smaller, but it doesn't always lead to them not growing back. So it does have some value there. It may have more value in the setting of the small micrometastatic disease. So this is where, like, maybe we just don't see it on your scan yet, but there are some tumor hiding out in there. So maybe you're going to resect some tumor, and then you do an isolated perfusion to treat anything that might be left over that you can't see. That might have a broader effect and a better long-term outcome. So it is done. There are some centers that do it. It's been around for a while, and it's never really picked up a huge amount because of the technical difficulty in getting it set up. It takes a little bit of work, and some you got to have some specific equipment for it, and it's unclear what the exact outcome is going to be. But there are trials going. It's a reasonable thing to be doing. Lung transplant was another question. So lung transplant for lung-specific malignancies has been around for a while. There's a type of pathology called adenocarcinoma in situ, or bronchoalveolar carcinoma. That's a lung-specific cancer, and transplants had been done for this before, and it is still considered an indication for transplant. Recently, it has been used for more advanced tumor, and that has been a couple cases that were done at Northwestern. They were publicized in the news. They never published those outcomes outside of the like press releases, so we don't really know what happened to those patients. The reason that transplant surgeons are, or anyone in the transplant community, is hesitant to transplant in the setting of malignancy is because you have to give someone very high doses of immune suppression in order to not reject the organ. And we now know that the immune system is a huge component of tumor treatment. That's why immunotherapy exists. And that's why many of you who may be aware of those, it's very effective in specific types of colon cancer. So if you give someone a lot of immune suppression, one of the side effects of it is development of malignancies. In fact, that's the most common thing to happen to patients after transplant, is they will develop malignancies of a variety of kinds. And so the worry is that if you immune suppress someone with metastatic cancer, you may just uncouple that cancer from the immune system and they will blow up with metastatic disease. So it has not been done, as far as I know, for colon specific. These were lung specific cancers, but that it may become a viable option in the future depending on what the outcomes from Northwestern show. But we don't have any real specific information about those two cases that they've done yet. Surgical approach to disease in both lungs. So great question. It's very dependent on the surgeon and the extent of the disease. My personal preference, I do 2 operations, space them 4 to 6 weeks out. If patients recover, you can space them longer if you need to. Why do I do it that way? Because the person who taught me to do it told me to do it that way. But it's also because my personal belief is that the disease rarely progresses in that short a period of time. You gain a lot of information every time you operate on somebody, and sometimes you gain an information that might change the direction of your treatment. In addition, one surgery on your chest comes with a certain set of complications, but if you have one, you've got one good lung that'll get you through. If you do 2 surgeries or operate on both sides of the chest and you have complications, you don't really have a lot of reserve. So I personally space them out. But one of my partners, who's a very experienced surgeon as well, he will do simultaneous a little bit more frequently. But then again, that's just his personal approach to it. I don't think either one is wrong. I think it's just however you want to do it and whatever the patients are most comfortable with. Consideration for VATS or open or robot. How do we decide what you do? Same thing, surgeon and extended disease. So what I ask myself as a surgeon before I'm going in to try and resect a lung lesion is, can I find it? Because your lungs are just sponges. And if you think about, or the way I describe it is, imagine if someone took a pea and put it on the inside of a dish sponge and now asked you, where's that pea? You can see it great on the scans, but you can't see it in real life. In fact, I don't ever want to see the tumor, because if I see the tumor, it means I'm too close. And so we need to be able to find them. And some of them are big enough that they can be seen on the surface. They kind of indent the surface of the lung. You can see it, in which case you can do a minimally invasive operation and just remove that area. Sometimes they're deeper in the lung or they're small, in which case you got to get a hand or a finger or something on it to be able to feel it and know where to cut. And so that's how I try and determine the best way to do it. Now, similarly, if I'm going to remove an entire lobe of someone's lung, for example, well, then it doesn't matter if I can feel the lesion or not, because that whole anatomic structure is coming out and I know how to remove that. And so that gets done minimally invasive, but it really depends on those issues. Some surgeons, and historically this was from some surgeons at Memorial Sloan Kettering in New York, had found that if they did an open operation where they got their hands in there, they would find more lesions than were seen on the scans. And that probably was true historically when CAT scans were a little bit lower quality and we were not getting as fine a cuts, or basically the images were a little further apart, so there were sort of gaps in the images, so to speak. And so they were finding lesions that they didn't see on the scans. Nowadays, with our very high resolution, thin cut scans, we probably don't have that same degree of an issue, but nonetheless, I think there is value to it in the right case, because my experience has been you will occasionally find a lesion you didn't see. You will occasionally find lesions you didn't see. And the only way to find it is systematically kind of feeling the lung with your hands. Liver and lung, What's the concern? Why does everybody worry so much about that? Well, again, biology is king. So if you have liver and lung, it suggests the disease is going to be more aggressive, but it doesn't mean it can't be managed. And so you stabilize it. And if it's completely resectable, then you address both, whether simultaneously or in a staged fashion. And so you can do it, but oncologists and surgeons all, when we see that sequential progression from liver to lung, you worry, are you capturing the disease at a point where it's sort of stopped at the lung, or is the next spot you're going to get a scan and you're going to see a bone metastasis, or you're going to see something else? So how do you know that you're catching it before it's kind of broke loose? And so that's really, I think, what the worry from a lot of providers is. When you start seeing that more aggressive biology, how do you address it, and can you address it? And I think the answer is you can in the right patient. You just have to find or understand that biology. So we talked about this maybe a little, or I don't think we talked about this quite yet, but yeah, can you have multiple surgeries on the same lung? You can. Hopefully you don't need it. So here's an example of a patient. This circle right here, this is a tumor in the middle lobe of the right lung. And this right here, this white line, this is a scar from a prior surgery. So they had a wedge resection, and they developed a new tumor in the other lobe. And so we took them back to the operating room. It was about 2.5 years later, and we removed this additional lesion. And so you can have surgery on the same lung more than once. I think the most I've ever done has been both lungs twice on somebody. And so if they have the lung reserve and we think that we're able to manage the disease, then it is something that definitely can be done. One more video. If anybody's concerned or doesn't want to see any, look away here for a minute. One of the questions I get asked is, what about lymph nodes? Because you'll hear your oncologist will say, well, you have tumor in the lung, but we see it in some lymph nodes in the chest too. And that oftentimes is where there will be a sort of a hard stop, or not quite a hard stop, but a soft stop. We say, are we going to resect this if it's involving the lymph nodes? And the short answer is, we know that if it's involving the lymph nodes, then it's the likelihood of controlling it goes down. It doesn't mean you can't, but it means it's harder to control. And so this video, the reason I show it is we see lymph nodes on a scan, and there's this sort of thought that it's a very discrete structure. But in reality, when you're looking at them, they're really not. It's kind of this sort of nebulous network of stuff. And so these are lymph nodes that are being removed here. This black circle here, this is a lymph node. But all of this sort of yellow fatty tissue around it, this is lymphatic tissue. And so as we're cutting through these lymphatics, but how do I know that node stopped right there? Because now here's the next node, this big one here is the next one in line. So you just kind of keep going, and these lymph nodes will go on forever and ever and ever, and you'll never quite get every one of them. So how do you know you've got enough? And that's why there's a worry that if the lymph nodes are involved, again, the biology of the disease might be different. And that's what that study that I mentioned before shows. Here's what a known involved lymph node looks like. It's a little bit stiffer, that sort of dark black pigment. There's not quite as much of it. And so this is removal of an involved lymph node. So again, we do it in the right setting. But this is kind of what it looks like. This is all being done again with a surgical robot. So that's what this looks like. And so I'll jump forward a little bit. You can see here's another node sort of hiding all the way up here. So we could keep going forever. Again, that's where it's hard to know if you're really getting everything out. Sometimes we do, but that's where coupling with systemic therapy is very important. All right, so that video is all done for folks who had looked away. Oh, that's it. So that covers, I think, most of what I had already questions we ran through. But if there's more questions or comments, I'd be happy to take them or address them now.
Great. Thank you. That was super informative. Thank you. Okay, so there are questions. So I'm going to running through them. Can you operate on lungs if there are few resectable lung nodes and hilar and paratracheal lymph nodes? Yeah, good question. So that last video, that was actually a combination of both of those. So one was a paratracheal lymph node, the one that was the bigger involved node at the last part of that video. That was a paratracheal lymph node.
And then the first part, where it's kind of the one that was coming out right at the start, that was a hilar lymph node. So you can, again, really what it boils down to is, do we believe that we're able to achieve control? And so if we see lymph nodes where it seems to be sort of tracking from point A to point B to point C to point D, where you know that you're not going to get, if there's going to be another node, point E, then we'll say, you know what, systemic therapy is going to be a better choice. But if we see isolated nodes and that's it, meaning they progress and it's just that stuff and they're not going to other levels, we give levels to the lymph nodes so we know when we're talking to other providers or surgeons that where things are. So if it's not going to a different station or different level of lymph node, then we'll consider removing those if that's our only site of disease and we feel that systemically we've got good control.
Great. So another similar question is about pleura and subpleural.
Sure. So pleura and subpleural. So subpleural, if you have what's called a subpleural nodule, the pleura is actually two surfaces. There's a pleura on the lung. It's basically like a sausage casing on the lung. And then there's a pleura on the inside of the chest wall. And so those two pleura are very sort of smooth, slick surfaces that allow the lung to move and rub up and down on the inside of the chest smoothly. If you have disease subpleural on the lung, that's just a lung metastasis. It's in the lung. It's just right at the edge. That's perfectly fine to remove. In fact, those are easier for us as a surgeon because we could see them. If it's on the other surface of the pleura, that is a much different sort of problem, because when you see pleural-based disease, the pleura is a huge surface. I mean, the actual surface on the inside is about yay big if you sort of unfolded the inside of the chest. And so if you see one or two nodules on that pleura, it means there's probably 1,000 more that you don't see. And so we worry when you have pleural-based disease that you can't control it because that whole surface is involved. That's what we call surface-based malignancy. Now, in the abdomen, there is the peritoneum, and that's the surface. It's the surrogate of the pleura in the abdomen. And there are procedures for the abdomen. That's where people discuss things like HIPEC surgery. That may have been it, or the intraperitoneal chemo for surface malignancies. That has been tried in the chest, but it has not been as effective as it seems to be in the abdomen. And so pleural-based disease, we frequently don't try and resect because we're never really able to control it very well.
Okay. How often is cleanup chemo used?
So I assume that means sort of post-resectional. That's a great question. It's very dependent on your oncologist and a couple of the other markers of the disease. So I'll give a few examples. If you have somebody who is a colon malignancy, primary was taken out, and on their surveillance scan 3 years later, they have one new lesion. Maybe it was even there the year before, but it's been just watched, and it's finally gotten big enough. Someone decides to do a biopsy and says it's a metastatic lesion. That patient might be reasonable for a primary resection. You remove that lesion, and you could reasonably say, I don't think we need to treat with chemo, because the disease interval has been so long that if there was more tumor, it should have progressed as well. And so maybe adding chemo won't help. Whereas if it's someone who 6 months after the primary, they've got 3 lesions, they got some chemo, they got a little smaller, there's nothing new, we might take those out and say, there's a risk there's still disease. Additional chemotherapy on the back end is probably a reasonable thing to do. So it's very disease specific or patient specific, I think.
Okay, great. A question about two approaches. You already talked about suffusion, but there's also in vivo lung perfusion that's being done in Canada trial. Yeah,
so those are more or less different flavors of the same soda. So it's essentially the whole premise behind it is you isolate the lung. The lung's a good organ. It's actually, oddly enough, a very close surrogate to the liver in how they behave. So you have a singular blood vessel going to it, and you have essentially a singular exit point, 2 exit points, but more or less one. And so you can completely control the blood flow in and out, or near completely control the blood flow in and out of the lung. And if you do that with clamps and things like that, you can then infuse almost anything you want into the lung, high doses of chemo, whatever it might be, to try and treat tumor that exists in that lung. And so whether you call it in vivo perfusion or infusion, suffusion, they're all really more or less the same thing, which is isolating the lung away from the rest of the body, so different blood flow, so that you can give enormous doses of it that if you gave systemically would make somebody very sick, or they wouldn't tolerate, or too much marrow suppression, et cetera. But that would be the reason for where that suffusion, infusion, it's all roughly kind of the same sort of thing.
Okay. I'm going to jump around a little bit. What is the percent of morbidity for surgery versus ablation, and the percent of recurrence of surgery versus ablation?
Sure. So let's do the second one first. The recurrence rates for, I can say for stereotactic radiation, which is probably going to be very similar to what percutaneous ablation would be. But for ablative procedures, the recurrence rates at 3 to 5 years, probably 3 years, is about 20%, maybe 25% in field. Okay. That was from a large series done at MD Anderson. If you look at surgery, the recurrence rate locally after resection is somewhere between 10 and 14%. So the difference is about 10 or 15% between the two in terms of local recurrence. I will say the caveat to that, or the caution to that, is with the ablations or with the surgeries as well, for those patients that recurred locally, a good percentage of them had new distant disease as well, which means it didn't really matter if their lung tumor recurred, because now they had 3 new tumors in their liver. So they the treatment of the lung turned out to not actually be a driver of their outcome. So there is a higher local recurrence rate with ablative procedures. That is we just know that exists. But the second part of that question, or the first part of that question, is what about morbidity? So morbidity of resection is dependent on the extent. But in general, for a wedge resection, the major complications, meaning heart attack, stroke, death, rehospitalization, is probably around well under 1%. For a lobectomy, removal of an entire lobe of the lung, it's about 0.5 to 1%. And then for major complications, and then probably on the order of like 5 to 8% for any type, meaning you have fluid in your lung that builds up, your lung collapses a little bit, you get an infection, probably in that range. For ablation, and I can't speak to percutaneous ablation very well for this, but for stereotactic or radiations, SBRT or SABR, the morbidity is, I'm not going to say 0, but it's very close to that. Most people have some fatigue and a bit of a dry cough. They can get a little what's called radiation pneumonitis. So that's inflammation in the lung that's managed with steroids, but it's pretty low risk. So that's the big differential between the two. Is one is a better local therapy, or I believe, again, I'm a hammer, it's the nail, right? It's a better local therapy, but it definitely has more risk. Radiation, better from a risk perspective, tolerated better for the individual, but higher risk of local recurrence. And so you should really, this is where you talk to your oncologist, or if talk to whoever you trust, and get a real handle on your disease. Because I tell patients, if I'm concerned that you're going to recur in 6 months, then get radiation. Because if you don't recur, and maybe a year later that field of radiation does start to grow, we'll remove it. We'll take it out then. That's not a big deal. But if I take it out and you struggle to recover, and 3 months later you're finally back to your normal life, and you get your surveillance scan and you have 2 new lesions, I didn't do you any favors. I just ruined your quality of life. So knowing how your disease is behaving is really important, and really talking with your oncologist so that you have a good, true picture of the expectation, and then you can make an informed choice about the modality.
Great. So question about lung transplants, which you talked to, but I'm going to follow up on that with a question around, living donor liver transplants are becoming more common with colorectal patients. I'm assuming you cannot do a living donor transplant for lung?
Well, believe it or not, there are living donor, or what's called the living donor lobar. That was actually initially the first living donor lobar transplants were done here at USC. We actually started that program. that technique about 25, 30 years ago. So you can do living donor lobar transplants. So what does that mean? You're right. You can't take out an entire lung from someone and give it to someone else. They would not be a great call for either one. But you can take a single lobe out, the lower lobe, in fact, of a large donor, put it into a smaller recipient, and that'll be enough lung for them. You have to do both typically. So you have to get a lower lobe from two different donors, one lower lobe on the left, one on the right, and then they go into the single recipient. So it is done. There has not been a living donor lobar transplant done in the US for a while. And the reason is, in the transplant community, it had fallen out of favor a little bit because it requires essentially 3 people or 3 patients at risk. You have to have 2 separate donors and a recipient. That's a lot. Liver, you have 1 donor, 1 recipient. And for donation of an organ, there needs to be 0% mortality for those donors. You cannot hurt those donors. And lung resections, just the risk is still there. You can't get it quite to 0. And so people have fallen out of favor because of the ability to obtain a deceased cadaver donor. Oddly enough, in Japan, they do a lot more living donor than they do here, but that's just because culturally there's fewer donors there.
And then will be based on what you talked about the immunosuppression nature of post-transplant, will the learnings from liver transplants in CRC be helpful in terms of what could happen with lung, or is it totally different in terms of how?
Yeah, good question. I mean, that's a good question. The short answer is yes, we have learned a lot. The downside is the liver is a special organ for a couple reasons. One is that regeneration ability, but 2 is the liver is actually like a giant immune organ. It's filled with immune cells. And so you can actually do mismatched donors. For example, in the lungs, we have to be matched, otherwise they'll reject. Liver, you can actually do a mismatched donor, especially in kids. Liver, they can be weaned almost completely off of immune suppression because the organ itself will not reject the same way because of the white blood cells or the lymphocytes that come from the donor. So all of those things actually make a difference for why you can get less immune suppression. For lungs, we unfortunately have not gotten that far. Lung transplant was the last solid organ to be transplanted. So liver, kidney, heart, pancreas were all done successfully. And in fact, the first successful bilateral lung transplant was done probably in most of our lifetimes. It was 1981. So it wasn't that long ago. And so we haven't gotten to a point where we're able to reduce the immune suppression enough to reduce that risk.
Thank you. You mentioned diffuse disease versus isolated mets in lungs. Can you tell more about the difference?
Sure. So when I talk about that, it's kind of a little bit of semantics, a little sort of dealer's choice, but isolated meaning just one. They're just one met. That's when I say isolated, I mean a singular. Diffuse, what does diffuse mean? That really just means more lesions or enough lesions that I would say there's a systemic problem that's existing. So if I see diffuse disease, I mean, I see 6 lesions on the left and there's 8 lesions on the right, but there might even be some microscopic lesions that, on the scan you may or may not be seeing. That's a more diffuse process, which suggests that there's probably a higher burden of disease. But to the original point, number isn't the hard stop, which is you might have that many lesions, but if month 6 you still have that many, and 6 months later you still have that many, then it's fine. Then that's controlled. But diffuse disease, in my mind, usually means you're seeing a lot of disease and you're seeing progression of new sites, which would imply the systemic problem still exists.
What are the complications of removing mets from lungs? What are the chances of spread into the pleura? And what are the outcomes for such patients? Could there be spread into adjacent tissue like ribs, et cetera? And what about mets in the bronchial tree?
Sure. Okay. We'll try and go through those. So risks for the removal of the lung. So if you have a positive margin, meaning if you cut and that you cut straight through the tumor, then it is possible for that tumor to see the pleura because you will have divided tumor and sort of spilled it. So that can happen. If you have a negative margin, meaning you've cut through and there's nothing there, so the tumor is totally encased, you never saw it, then the risk of that pleural-based seeding should be pretty low. Now, if you have a tumor that is on the pleura, or what someone earlier asked about subpleural, if you have a subpleural tumor that is eroding through the pleura, and often we can't see that visually, that's something they only see microscopically, they can develop pleural-based disease. And that's just because the disease biology, it's eroded through and it spills tumor. What are the outcomes for those patients? They're not as good, to be frank, because we can't find a way to control that disease very well. And so it's not locally controllable, unfortunately. So yes, you can develop that in the event that you had a grossly positive margin. A microscopically positive margin, the likelihood of that is markedly lower. And I don't think I've personally seen that before, but it can happen if you spill tumor grossly into the pleura. Was that, there were a couple questions there. Did I answer all of the ones?
What about spread into adjacent tissue like ribs?
Oh yeah, and bronchioles, right. So adjacent tissue, yeah, similarly, if you have a local recurrence, it often means, like, if you cut through on the staple line, and then so you cut and we have a stapler, and so then the lung sort of falls back down on top of that area, you can have that local recurrence happening at that surface. So it could grow into the lung from that area. So if that happens, then again, that's where we would say, well, you can re-resect if you have to, you can radiate if you have to. Those are appropriate. And then in terms of the bronchial, metastases to the windpipe or into the airway is relatively uncommon. You can see it from time to time, but it's not frequently seen. And so spillage of tumor to like into the airway is pretty rare.
Is there a difference in technology across major centers? For example, are there better robotic tools at specific hospitals or the same everywhere?
Good question. So short answer is there's basically one robotic platform that exists in the United States. It's called the Da Vinci platform, which is made by Intuitive Surgical. They are effectively in a monopoly. There is like a couple other very small startup companies that have a few robots out there here and there, but that's basically the only one that the majority of centers use. I personally don't know any center that uses a different robot. In terms of other technologies for the treatment of the malignancies, some of those other things like isolated perfusion, that's something that's only done in certain centers, transplant only certain centers. Robotic bronchoscopy is something that exists now, and that's a handful of centers have that. That is helpful for diagnostic purposes, but it's also going to become probably more important for ablation, because you can actually find difficult to identify lesions and ablate them through the windpipe. So having robotic bronchoscopy is probably an advantage at certain centers if they offer transbronchial ablations through it.
And is it LAPM, whatever it is in Germany, that do people need to go to Germany because they do something there that we don't do here?
So this is the like laser assisted. I honestly don't exactly know I think what they do is use something called the argon plasma coagulator, which is a device that we have here. And it's a way of just sort of carving these lesions out using an argon beam. It's not a bad technique. In fact, it's probably pretty akin to what the liver surgeons do sometimes, which is they use the argon to sort of carve out lesions in the liver. We don't use it as much in the lung just because we have to seal the lung afterwards. And so any type of thing that sort of cuts or burns into the lung can then lead to leaking of air afterwards. And so stapling or wedges using staplers are effective in that manner. But for lesions that are hard to identify or you can't get a stapler around it, we do carve them out in a similar manner. But I believe that's what that technique that they're doing is. I'm not 100% familiar with it, but I've heard it before. I've had a few patients who actually have had surgery overseas, and they had that done. I actually operated on one a second time after they had that done for another tumor, and the operative field looked similar to what we would normally see.
Why do oncologists and oncologic surgeons sometimes say they're more concerned with liver mets versus the lung, even if there's multiple spots in the lung?
If I were to hazard as a non-liver surgeon, which is when I see the liver, I made a wrong turn. And so as a non-liver surgeon, I would think that one of the concerns is probably the ability to achieve a complete resection. And so just like the lung, you have to leave enough behind for someone to survive. And the liver, similar to the lung, has these sort of anatomic subunits where you can do a lobe of the liver or a wedge of the liver. Again, it's very akin to it. They're sort of very analogous. But often I think their concern is the liver is a little bit of a smaller organ, and so there's just less space. And if there's a bunch of metastases, they may not be able to get them all. And if they can't get all of those lesions, then, as we said before, there's no point in addressing the lung if we leave a bunch of tumor behind, because we won't have a plan for everything. And so that's where that comprehensive sort of strategy becomes relevant. But that would be my thought as to why they're very worried about the liver over the lung sometimes.
Is there a pattern for where lung mets tend to progress, like to the liver, peritoneum, bone, brain?
Yeah, so good question. For patients with like rectal malignancies that bypass the liver entirely, then bone metastases or lymphatic involvement tends to be what you see occasionally. It tends to be that we don't think the metastases kind of lead to new metastases all that frequently, but if you have very big progressive like lung lesions, we sometimes will see them then in the lymph nodes within the center of the chest. We don't know if that's a chicken and egg phenomena, which one came first, or maybe they're two different things. But occasionally you can see that, I guess. But yeah.
Okay. For liver surgery, KRAS and TP53 mutations are relevant for recurrence and SMAD4. Are there any mutations prognostic in lung surgery?
So I don't think there's anything prognostic specific to lung. But yes, those different genetic driver mutations are relevant for the tumor overall. So for folks who have MSI high, for example, so that microsatellite instability is a term sometimes people hear, those tumors where we expect them to have a lot of genetic instability, so they're very immunogenic, where they're going to respond well to immunotherapy, for example. Those are patients where I'll have a discussion with the oncologist and say, we have someone who's MSI high, has a couple lesions, and we've got a good opportunity for therapy with immuno. Maybe we'll be more aggressive with resection because their recurrence rate globally is going to be different. But I'm not familiar with any driver mutations that would alter lung-specific surgical intervention.
In liver, there is data that says there's better overall survival for patients who have had resection. Mm-hmm. Is there something similar in lung?
Good question. So the short answer is sort of, and the longer answer is it's complicated. So what do we mean by, so I guess I'll put it like this. If you take a population of patients and they develop lung metastases and you resect them and you fulfill the criteria, systemic control, all disease resected, primaries managed, then, you know, depending on which series of patients you look at, somewhere between 20–40% of patients will be disease-free at 5 years, or effectively we say cure at 5, right? And so those patients we think do better than the patients that you didn't resect. The problem is there was only one trial ever done to try and compare directly operating on patients or not operating on patients. It's called the PALM-MIC trial. It's done in Europe. They didn't accrue enough patients. It took them like 15 years to do it. And when they did a comparison, the outcomes were very similar, but nobody really believes it, to be honest, because the numbers were so small. And so we have data that supports it retrospectively. So we have a lot of data that supports it retrospectively, that if you operate on these patients, they do better than patients you don't. But we don't know if we've already pre-selected them, meaning if you get to see a surgeon, it means that you didn't progress long enough. So maybe you're going to be fine no matter what we do. But yes, so it's very similar to the data in liver, to be honest, which is it's all retrospective, but it does support resection in the appropriately selected patients.
Okay. Two last questions. Thank you for staying longer. If you're doing watch and wait for rectal cancer and you develop lung mets, does that mean watch and wait failed?
No. Short answer to that one. No, it doesn't mean watch and wait failed. Because, you know, this is where when I say I don't understand cancer, I think I'm being honest. You can completely treat a primary, you can take it out, and you can have no tumor for a year. or 18 months. And then all of a sudden, you start to see tumor grow. Why did that happen? Because that tumor in your lung, it didn't show up that month. It's been there since your primary tumor was there. So there was no way to predict that really well. Again, we're trying to learn surrogate markers to predict it. And so I think in general, I wouldn't call it a failure. I would just say this is the disease biology. This is where the biology is king. And so we don't know how to predict that. We don't understand it. We do think it's something to do with your immune system, where for whatever reason, the immune system is able to keep that tumor at bay long enough. And that's what happens. But no, I think a failure of those is not as much a failure of your treatment. It's just a disease behavior that we just don't quite grasp. But those patients who, quote, fail in the sense that they do progress, they're still candidates, right? Because you say, well, they progressed here, but that's it. And you get the systemic and nothing else changes. Then you take them out and then you reset the clock and we go back to watch and wait and we see what happens.
Okay. Another question is in terms of when to seek a surgical opinion. I know you talked about talk to your oncologist first and then seek it, and also seek a surgical opinion. But we have a lot of patients, right, who their oncologist will say you're not a candidate for surgery.
Yeah.
So what are your thoughts in that in terms of how early do you like to see patients in the?
Sure. I would say oncologists they're smart individuals. And so I wouldn't want to doubt the judgment of those individuals. But I will also say this. Oncologists aren't surgeons, just like surgeons aren't oncologists. If someone asks me what chemo to give, you're going to get a blank stare. But if somebody asks an oncologist what surgery to get, you're going to get the same answer. And so I think that if you have any concern or any doubt, not even a doubt, if you just want to hear an opinion, I would ask for it. Because it's, from my side, if I see a patient and they're unresectable, I'm not upset about it. I mean, the patient's the one who's got to deal with that, but it doesn't bother me to say, look, I'll give you this information and maybe there's some other options that are available that we can help provide for for symptomatic control and things along those lines if you are symptomatic from the Mets. But there's really no reason not to, because you will find that there are oncologists who are more aggressive in asking surgeons to see their patients, and there are others who are less aggressive. And you will find surgeons who will say, yeah, this is definitely resectable, whereas an oncologist might have had a concern that it wasn't. And so it's not that they're wrong. It's just, it's not exactly their field. And so, like, again, I'm not going to tell them what kind of chemo to give. And so if you have any worries or you just want to hear from it, just ask to see a surgeon. I don't think most of them would really be averse to that. In fact, a lot of them would be more than happy, because if you're interested in surgery, then, and they know, and someone says there's an option, I'm sure they would be thrilled.
Well, thank you so much. This was super informative for me, and I think a lot of people are commenting the same. So thank you so much for your time. Thank you for all your thoughtful responses and information. I think it's extremely helpful to all of us. You are very welcome. I know we had a lot of questions in the chat. Hopefully we got through most of them. I think I did. I think I did. And if I missed your question or whatever, I can send them to Dr. Atay. If you whatever's left over, shoot me an email or whatnot. I'd be happy to respond. That's no problem. So again, thanks for having me. I'm sorry I had to skip out on our first run through here. But it's great to be able to meet everyone here via the Zoom and answer. It would be informative. Well, and as patients and caregivers, we know that some of those things you get pulled away for. We've been on the other side, and we're glad you were pulled away for it. So appreciate that. Okay, thank you so much. Okay, bye-bye, everybody. Bye.